Hello everyone. My today's discussion will be sharing a wonderful experience which I had recently on airlifting the patient from Ahmedabad to Chennai who was on ECMO for lung transplantation. When to do airlift? When the patient is unstable, or rather you can say unable to sustain with current situation and he requires higher treatment. It is a preferred choice to avoid life-threatening situation. Shifted for fast lung transplant post-COVID patients nowadays. It is the fastest route where timing plays a vital role. These are the advantages of shifting the patient on airlifting the patient. Mostly it is helpful in severe respiratory support and immediate shift to higher centers. It helps in stabilizing the chronic condition before reaching the destination. All basic and advanced respiratory, medical ICU, circulatory, critical circulatory care services are available. Continuous and close monitoring during evacuation by the expertise team members. It reduces the chances of morbidity rate due to respiratory problems. Then how the patient is transported. After a successful consultation, air ambulance team reaches the destination, asks or collects information about the ongoing therapy, diagnosis, treatment, and then after all parameters, a quick back-to-back transfer is done, and then the journey is started with all the possible safety measures. During the evacuation, all possible treatments are given to stabilize the traumatic situation before reaching the destination by the team. And then finally, a patient is transferred to the desired hospital for the better treatment. These were the patient demographics. Condition of the lungs were very bad. It was a post-COVID patient and plan was for the lung transplantation. ECMO was initiated after the COVID report was negative. 60 years of age, weight was 75 kg, and no other challenging history was found. Here our journey started at Ahmedabad Hospital. Patient was on high ventilatory support and the mission was executed on the 16th day of ECMO. These were the hemodynamic parameters: heart rate of 112, blood pressure of 180 by 80, saturation was 80%, hemoglobin was 9 gram. Ventilation support was FIR to 100%, respiratory rates of 14 breaths per minute, tidal volume 130 ml, PEEP was maintained to 0. It was a good renal clearance. Urine output was 100 to 150 ml per hour. Normal neurological state. No other infection was found. The cannulation site was clear and no soakage was found. Lactate level was 2.8 millimole per liter. These were the ventilatory management during the evacuation, during the fly. PEEP was 0, PIP was 60. Plateau pressure, that is a pressure exerted on a small airway or alveoli, which was around 62, maintained to 62. Tidal volume was 160. Baby lung ventilation was initiated. That is a small amount of respiration just to keep the lungs in a normal breathing state. In an adult was the important aspect over here. Sedatives was in a plane 4 state of anesthesia. Patient was in a deep delta 4 stage of anesthesia. When we were lifting the patient from ambulance to aircraft, higher dose of anesthesia, that is a deep sedation was given and the patient was completely sedated, and then we started with our journey. Atracuram and midazolam were the sedative infusions which we had. These were the ECMO parameters. Pre-membrane oxygenation was 30, post-membrane oxygenation was 400. Pre-membrane and post-membrane oxygenation was also good. Blood flow rate was around between 4 liters, 3.8 to 4.2 liters, fluctuating, 4 liters approximately. Cannulation site to IJV to femoral, 19 French and 23 French of cannulas were used. ACT was maintained to 170 to 180 seconds. Oxygen supply was 8 to 10 liter per minute. No other inotropic support were required. We were on the standby if any required, but patient was stable, except lungs, each and everything were in a stable state. So no other inotropic supports needed. Heparin infusion was started along with the sedatives. The year we reached the destination at Chennai with a very good state as compared to the patient we lifted in Ahmedabad. The patient was in a quite stable state with a saturation of 98%. Pre-membrane and post-membrane oxygen was 83 and 400. Lactate level came down to 2.2, hemoglobin hiked to 10 gram per deciliter. From this journey, this is a take-home message. The conclusion, what we can conclude is close monitoring is always required for a good sign of alertness. Effective communication is must with the team. Sufficient amount of battery backup is required. We had a dry battery with us, which was having a backup of 4 hours, or else we can, or one can also carry another ECMO console, which is having a battery backup of 120 minutes. Then prepare for all possible emergencies and their rescue solutions. What I had faced is one of my experience, what I would like to share with you. When we just take off from Ahmedabad, there was a good weather, good sunny weather. So patient was in a stable state, but when we were about to land, and while landing, the ECMO parameters, that is the LPM, was fluctuating. For a few moments, the machine was not showing any LPM. It was not because of the lack of jelly, but still, what I did is I just clamped the line of the pump, applied the jelly within 30 seconds, and then again uh, assembled. I kept the pump in the console and the roller centrifugal pump, and then started the pump, and then it showed the LPM. Again, it was happening for twice or thrice. It was happening while landing because weather was not good. Air turbulence was there. It was quite raining there in Chennai. So I had a clamp and jelly with me, and this was what I did was, one must need to study the geography of the distance to be traveled and accordingly keep all possible medical treatments on standby. It is necessary that how far you are traveling, which is your aircraft, what is the speed of the aircraft, what is the duration of the journey, and prepare yourself for the necessary backups. If possible, create a green corridor for quick and early transport. These were our aircraft details. B200 aircraft, cargo door, speed was 500 km per hour, multi-engine aircraft. Our total fly was 3 hours and 25 minutes from Ahmedabad to Chennai. These were our team members, led by Dr. Navneet Singh, senior anesthetic, myself as a perfusionist, and one of our paramedic assisting staff, Mr. Sunil Singh Yadav. This was our pick when we had takeoff, and after an hour when the patient was in stable condition, this was our pick. This is our team member. This was the aircraft in which we went, and that was a really wonderful experience what I had for the first time, and many more expected in the upcoming days. And I'm glad and I'm thankful that I got this opportunity at a very young age. So, and finally, I'd like to thank the ISEC team for giving me this wonderful chance and giving me the opportunity to come and speak or share my experience on this board, and would be glad if I get any questions and will try my best to answer all. Thank you so much.